All right, everybody, to follow up on our last lesson, which looked at physiological changes in the aging, this time we're going to look at sensory changes in the aging. And make sure that you read, if you have not already, Chapter 4 within your Bolt's textbook to follow up on this presentation. So senses are a huge part of our life. They enable us to interact with the environment around us, and this is true for older adults too. Whether it's watching their grandson play t-ball, listening to their favorite choir at church, whatever it is, it all leads to their quality of life and their level of independence and function. So just an overview of the objectives for this lesson. We want to describe changes expected within the senses with aging, identify common disorders that put older adults at risk for sensory impairment, appropriate assessment techniques, nursing interventions that we can implement to help our older adults manage sensory impairments, and then also how we can collaborate with other members of the interdisciplinary team to help our older adults. So before we get started, I want you to turn to your neighbor beside you, talk about an older adult in your life that has a sensory impairment and ways that their life is effective or things they have to do to help manage that sensory impairment. All right, so now that you've done that, we're going to go to our first sense, which is vision. So what's expected is in regards to vision with aging. The eyelids start drooping, which can make it hard to see from side to side. Pupils are slower to dilate and contract, which makes it hard for them to go from dark to light and vice versa. Lens, the elasticity starts to go down, and the stiffness within the muscles isn't as much. So it makes it really hard for them to focus on small things like fine print in this newspaper or dilate to like see in the dark, so drive at night. Common disorders, macular degeneration, cataracts and glaucoma. You really need to follow up on that in your textbook and make sure you know about those. So assessment, certainly that's going to be grounded in a strong health history. Do they have diagnoses like previously discussed, or do they have other diagnoses like hypertension and diabetes that could put them at risk for vision impairment? Eye exam, certainly we're going to look at the eyes and do a thorough eye exam, but also consult with optometrists and like that to do a thorough eye exam. Also, we're going to assess their vision. Can they see? Can they read? That's something we need to think about. Can they read the fine print on their pill bottle and the education instructions we're providing, or do we need to get large print or make other arrangements to look at those things? This is certainly very important because if they can't read those pill bottles, they're really at high risk for a medication error, things like that. So we need to really pay attention to vision. So nursing interventions, what can we do to help these patients? Assessment, very important. Lighting, they need to be able to see where they're going. So when you go in that room, you start getting them up. Turn the lights on. Encourage them to do the same at home. Glasses, if they have them, use them. You know, if you go in the patient's room and they got their tray in front of them, help them put their glasses on so they can see. Whenever you're interacting with them, or they're moving and grooving, or whatever they're doing, encourage them to put on their glasses. And if they don't have their own personal glasses available, see if your hospital or facility has just the over-the-counter available that you can use for them while you're working with them. Also consider, do we need to use large print? Surface contrast is important, and this is an education opportunity for the patient and their family or caregiver. You know, if they'll put a strip on the stairs so that they can see the stairs, make a contrast in the color, that can really prevent falls. And again, it's important for us to collaborate with other members of the interdisciplinary team like an optometrist to make sure that vision is taken care of. So hearing. We all think about Granny saying, huh, what are you saying? It is very common, hearing loss is, within older adults. So what puts these older adults at risk for that? So the hair fibers, they start to lose their function. They're not able to clear out that earwax. So they're more at risk for getting impacted from earwax. Also, just the process of sound through the ear canal is impaired with aging. And the processing of sound by the central nervous system is impaired, which makes it more difficult for them to hear the higher frequencies. That's why it's hard for them to hear women and children, but they can hear the low bass tones, and we need to remember that when we're talking with them. Common disorders, there's several different types of classified hearing loss. Tinnitus, ringing in the ears, Meniere's disease, I'll let you read more about that in your textbook, but that's something that's important to look at. So assessment, certainly want to look at the ear. Is there buildup of earwax? In the conversation with the patient, are they saying honk? Can they not hear you? And it's really important for us to consider that if they can't hear us, we need to do something. And what can we do? Certainly working with the primary care provider to look at why are they not hearing. If they have hearing aids, we need to help those patients use those hearing aids. Help make sure that the batteries are going. If the battery isn't working at all, they won't work. Or if it's about to go dead, they're going to be ringing in their ears. We need to encourage them to put them on. Also, if there are a patient in the hospital, it's our responsibility to help keep up with those hearing aids and encouraging them to use them. Then pocket talkers, and you'll see a picture of that at the top of the slide. It's just a little box you talk into, and either it comes with earbuds or headphones. It can make a world of difference in hearing for your patient. And these are like $30 online. So that's something to consider. That it just amplifies the sound and can really help with the interactions. I encourage you to use those as you're caring for your patients, and encourage the family members and the patient to do that as well. Communication techniques, just want to make sure we're looking at the patient. Talk with those loud, slow, bass tones. And then monitor it. Does it look like they're understanding you? Ask, what did you get out of this discharge teaching, to make sure that they're actually understanding you. Because really, if they can't hear, it really does decrease their quality of life. Then a third sense is smell, something we don't often think about, but that can certainly happen. It's not expected, but it is common with aging. It's usually associated with Alzheimer's or Parkinson's disease. There's different disorders that can cause smell, and I'll let you read more about those. Assessment, we want to look at decreased appetite. A lot of that times, if you can't smell what you're eating, you don't want to eat. So that can be one of the first signs that they're having trouble with smell. Also, if they start coming in with diarrhea, nausea, vomiting, could it be they're eating bad food because they don't smell it? And that's something where we need to dig a little deeper as nurses and look into that. Certainly, again, just like with vision, there's a risk for taking the wrong medication. With smell, if they can't smell smoke in a case of a fire. So if they have trouble with smell, we need to look at encouraging them and educating them about the importance of smoke detectors and things like that. So interventions, what can we do? Certainly starts with an assessment and thorough history. If we notice an acute change in smell, we need to consult that doctor. Consult that primary care provider. And again, patient teaching. If it is something that is happening and is present, educating them about making sure they have the smoke detectors, things like that. Or are they making arrangements to make sure that the food isn't going bad, that they're not able to smell it. Then taste. That's our next sense. Very closely related to smell. Certainly, with aging, it's not expected that they lose taste, but it can happen. And often it's related to dental problems, diseases or illnesses like infections, medications, or treatments. Let's see. There's different disorders. Burning mouth syndrome, dry mouth. Burning mouth syndrome is where they have this sense of burning or tingling in their mouth. And a lot of times that's associated with acid reflux, vitamin B12, or thiamine deficiency. And then dry mouth is a huge side effect of a lot of medications that older adults take. Anticholinergics, antidepressants, Parkinson's medicines, all those things. So that's something important to think about. Assessment, again, just like medication history, or medical history, and then here are the medication history, because you want to identify medications that may be affecting their taste. And then also a physical exam, just are they complaining of not being able to taste their food. Nursing interventions, what can we do? We want to complete, again, that history, notify the doctor and a specialist as needed, and then just the patient education. If we identify that they're having trouble tasting their foods, they may be eating bad food, and we need to work to make sure that they have a method, whether it's dating the food as they put it in the refrigerator or whatever, make sure they're not eating bad food. And again, collaborate with your pharmacist and your doctor. If it's identified that one of the medications they take makes dry mouth or makes their food not taste good, we may look at getting another medication. So, Another thing is touch. And this is a pretty big one that affects older adults. So, expected changes with aging. Peripheral nerve function is known to decline with aging, and that affects the sense of touch. Again, also they have a decreased ability to feel pain sometimes. You know, we think, oh, they don't hurt as bad, but that can be dangerous, and we'll talk about a little bit more about why that can be dangerous. And then even if they feel pain, they're not as able to pull away from it as fast as younger adults are. So common disorders, and we're going to dig a little deeper here. Peripheral neuropathy, just nerve damage within distal extremities. This can be caused by circulatory problems or vitamin deficiencies. Then diabetic neuropathy is a huge one, just where they lose feeling in their lower extremities, and most often their feet. And most often in patients with diabetes, older adults with diabetes. If they can't feel it, they don't know they have a bad wound there, it gets infected. You know that with diabetes they don't have as much blood flow, so this really can be a recipe for a bad thing. So with your diabetic patients, you want to really encourage special foot care. Look at those feet. Make sure that there's not a wound there. If there is, we need to address it. Also, acute sensory loss can occur as a result of stroke, compartment syndrome, just several different things there. So assessment, again, is huge in assessing touch in older adults. Can they feel their extremities? Look at those feet, especially in those diabetic patients. Is there a possibility they have a wound that they don't feel? So nursing interventions, again, complete physical assessment and a history, collaborating with that physician. If you see that they can't feel it, talk with that physician about how we can manage that. Make sure that you refer like a diabetic patient to a podiatrist. They need to be going to see those, so collaborating with the interdisciplinary team. Patient teaching is huge here. You know, we need to work with physical therapy to help them learn how to mobilize safely when they can't totally feel their feet. Teach them about foot care, looking at their feet regularly, keeping shoes on, especially in those diabetic patients with neuropathy. And then fall precautions. Again, that's something we always need to look at if people have problems with touch. So those are our senses. Again, just to reiterate on this slide, interdisciplinary partnership is huge. We can't do this by ourselves. We've got to be communicating with the primary care provider, with those specialists, whether it's the optometrist or the ENT or whatever it is, physical therapy, dietitians, all the pharmacists, all those are great people that we need to be collaborating with. Again, the nurse is with the patient, we're leading it, but we got to collaborate with them as well. Now, real life role play. So we're going to celebrate. We got cookies and drinks. You're going to go up into pairs. One person's going to be the caregiver. One person's going to be the older adult. You're going to put on these replicators, and you'll see those laid out. You're going to have cotton in your ears so you can't hear, garden gloves on your fingers so you can't feel, and you're going to see what it's like to be an older adult. So put on your assigned replicators. When you go to the cookies, one person's going to be the patient or the older adult, and then you're going to swap roles. And you're going to go get your drinks. We're going to swap around. Everybody's got to be the older adult one time and the caregiver one time. We're going to see what it's like to try to do these activities. Not being able to hear, not being able to see. You're going to have on your special glasses to augment your feelings. And then after you get back down with your refreshments, we're going to talk about what it was like to have a sensory impairment. That's all I got.